Very much, Ronald, and I invite Dr. Vishal Agrawal. He will be speaking on the role of ultra-wide field imaging in everyday practice.
Sir, next question will be ready there. Vishal is connecting the laptop.
Yeah, next speaker, if they are ready, yeah. No problem. I think Krishnendu Nandi is here. Yeah, okay. You be ready with this. Okay, thank you.
I'm ready, sir. Thank you, everybody, and good morning. I'll be speaking on the role of ultra-wide imaging in everyday practice, and specifically, I'll be using my experience in this presentation of the broadline fundus imaging, which I use regularly. So just brief about the basics. Standard fundus photography, as we all know, is 30 to 50 degree image, limited to the posterior pole. And even in the ETDRS, where they montage 7 standard field images, it led to a field of 75 degree. The retinal periphery for a very long time still couldn't be adequately visualized. So we have a nomenclature now, which says that posterior pole is 50 degrees, and 60 to 100 degrees is classified as wide field, and more than 100 degree is far periphery. Pan-retinal, that is 360 degree, is still in the making, and right now no machine can capture the image of an entire retina. So this is the UWF of the Claris I use, and these white circles are the ETDRS, that is 75 degree, and you can imagine how much area we were missing previously, even after montaging. So a small slide about the optics. So it's a white light, it's a broad rectangle of light. It is scanned across the retina, and it is detected using a monochromatic camera. And there are 3 LEDs, red, green, and blue, and that leads to a true color image. So the concept here is by using a slit to illuminate a portion of the retina, not a flash, the broadline fundus image limits unwanted scattering and reflections with, as compared to a flash-based camera. So apart from a wide field photo, it gives you angiography, it gives you, autofluorescence, external photo, and of course, various filters, red, green, and blue. And the color is actually what you see on a 90D or an indirect examination. So this was a disc edema, and after a posterior septal steroid injection, you can see the change, and you can see the clarity and the margins of the disc, almost as true as what you see clinically. So coming to the clinical cases, as I told you, it is a multimodal imaging system, and it has both blue and green autofluorescence. You can see the images here, and of course, coming to the vascular disorders, this was a proliferative diabetic retinopathy. You can objectively quantify where the areas you have left after PRP, and if you want to augment, you can see the CNP areas or the skip areas and magnify them and do a targeted laser therapy. Again, an image of proliferative diabetic retinopathy. Here you can see the 200-degree view of this system and the fanning of vessels, which is more clear without even an angiography on the red-free photograph, and you can see all around a florid neovascularization on this image. And again, a targeted approach is very helpful rather than barraging the whole retina and limiting the field of view of the patient. So these photographs, what I'm showing you, are all for this presentation undilated photographs. The patient comes in, gets an ultra-wide field photograph, and you can see the extent of retina we can imagine. So this was he was a doctor, he was a dentist, and he came with sudden onset of floaters. The vision was 6x6, and you can see there's a nasal large horseshoe tear with a little amount of vitreous hemorrhage, and we barraged the patient. And for prognostic purposes also, this patient is a 40-year-old female with Stickler syndrome. One eye I had operated, and the second eye also got a detachment, and the patient was 6x6, and the patient denied surgery because he said, I have no problem in my vision. I'm just seeing a shadow, and I'm just seeing some floaters. And 3 days after, when the macula was involved, you can see the vision dropped, and she came running again that I need a surgery immediately. So you can prognosticate. You can tell the patient that I told you, of course I will operate and the retina will get attached, but the prognosis remains fair as compared if I had operated on you 3 or 4 days back when the macula was on. You can evaluate your pre and post-ops. This is a giant retinal tear, and this is the first post-op day with the undilated pupil. You can see the laser marks, and you can see check for residual fluid or skip areas if you want to augment laser in these cases. And this is the clarity which it gives you even in post-op day 1 when the media is slightly hazy. post-op buckling patients. You can see the pediatric patient with multiple lattices and holes, and you can see the buckle effect and the cryo effect in these cases. So these are very interesting cases, when you are operating on high myopes or in choroidal detachment cases, and then you see in the post-op period. So this shadow is actually not an artifact. This is basically signifying the underfill of the silicone oil. And in these cases, you have to be careful to, examine the inferior periphery in the follow-ups and to augment laser wear, because these are prone to recurrences because you have underfill of silicone oil in these cases. Coming to inflammatory pathology, multifocal choroiditis, Ozurdex implant in place, all undilated photographs, and you can see the post-Ozurdex follow-ups. The areas of the active choroiditis have been resolved, and you can see the crumpling and the absorption of drug from the implant. And coming to the angiography, if you use a 40 or 50 degree camera of the posterior pole, you can easily miss the CNP areas in the periphery, like in these cases of vasculitis, and you will not laser them, and they might turn up with neovascularization or vitreous hemorrhage in the follow-up periods, because you never knew that these CNP areas existed in the periphery with conventional angiography systems. This was a patient, a 10-year-old girl who presented with sudden vision loss, and the parents came, and this was, there was a CNVM in the posterior pole, 10-year-old girl. And when we did an angiography, you can see in the far periphery, nasal as well as the temporal, you can see these inflammatory leakages, and it was an inflammatory, post-inflammatory CNVM. Patient was injected with the anti-VEGF and did fine. Coming to these cases of post-op period, this was a macular hole operated. The hole was closed. It was a type 1 closure. The patient was not improving beyond 636. It was so if you use the blue channel, you can see all these marks around the fovea. This was an optic nerve fiber layer.
You have 1 minute to conclude.
1 minute, sir? Let's conclude. So you can prognosticate the patient, and a recurrent vitreous hemorrhage in a 50-year-old female, no cause was seen. We did an angiography, a temporal vasoproliferative tumor was done, a cryo and laser was done, and the patient did fine in the post-laser period. So pediatric imaging is a slightly skillful job, but it takes only 3 or 4 seconds. Leber's miliary aneurysm, you can see the CNP areas, and this one was the recent. The patient was a 6-month-old male with tuberous sclerosis, and you can see the retinal hematomas. It's a 3-second click, and you can get a wonderful picture of the posterior pole. So to conclude, indirect ophthalmoscopy still is the gold standard, but this is the true color imaging. Ultra-wide field is the next best thing, maybe better in some cases, because indirect is a poor and a subjective documentation. It's difficult to implement in a heavy workflow. You cannot do justice in every patient. There are dilatation problems and long waiting times in a heavy OPD. So the BFI advantage of ultra-wide is that it is a game changer in the future of ultra-wide field imaging. Aids in observing, documenting, and treating areas. And it's an excellent adjunct to pre-operative cataract workup also, and for the counseling of the patient. Excellent HD resolution, near zero artifacts are the major benefits. Of course, the caveat is cost. Cost is still a prohibitive factor. Thank you.
Excellent, Vishal. But now, I think recently the Seva Foundation has sponsored a camera for Remedio, and they made a ultra-wide. I don't know how I have to see in the exhibition available, but I hope the cost will come down. Definitely, I think the ultra-wide field will be to go to the future.
Yes.
Yes. Dr. Vishal, you have wonderful collection or album of varieties of retinal images in a wild field images. Can you tell the audience what difference it made in your practice after ultra-wide field imaging and before that?
Huge difference, sir, because especially in a high volume retina practice, I cannot, there's a human fatigue factor in every patient. I cannot do the same meticulous indirect in my first patient and the same meticulous indirect in my 60th patient. So sometimes, you tend to miss things, especially in uncooperative patients. Sometimes the technician also says, sir, ye hole dikh raha hai supratemporal quadrant mein, and you again see the patient, and actually there is a hole which you missed because of a fatigue factor. So you have to, be objective in documentation, and this helps a lot in that case.
Thank you.
Yeah.
Any questions from the audience? If no questions, then we will invite